Now I'd like to invite Dr. Sajjad Ali sir to present on pancreaticobiliary system, normal anatomy and their variations.
A very good morning to everyone. The topic given to me is multimodality imaging of pancreaticobiliary tree, its anatomy and variations. So we will discuss the topic under the headings of embryology, normal anatomy, imaging modalities, variations of the biliary tree, variations of the pancreatic ductal system, and its surgical significance. To start with, the biliary tree and the liver develops from hepatic diverticulum. It is the first analogy of the bile ducts and the liver. It is derived from the ventral foregut with endoderm. The biliary tract begins to form during the 4th week of embryonic development. The cranial part of the hepatic diverticulum forms liver and the bile ducts, and the caudal parts form extrahepatic bile ducts, the gallbladder and the ventral pancreas. Extrahepatic bile ducts develops between 4 and 8 weeks. CBD and the ventral pancreatic duct rotates 180-degree clockwise around the duodenum. By 6th week, the bile duct and the pancreas ducts end in closed cavities of the duodenum early in the 7th week, and development of intrahepatic ductal system is completed by 10th week. I'll go a little faster to complete the topic within stipulated time, so just don't mind. Development of liver and biliary system, it starts by 4th week through liver bud. It's from the cranial part forms the parts hepatica, which forms the intrahepatic biliary tree and the liver and the cords of hepatocytes, and the caudal part called the pars cystica forms the gallbladder and the cystic duct. As the cranial part grows, it divides into right and left hepatic ducts, which forms gets canalized and forms right and left hepatic ducts, and it undergoes further division to form intrahepatic biliary tree and the cords of hepatocytes. The caudal, the distal part, gets canalized, elongates and form the gallbladder and the cystic duct. This is the fate of various structures of the biliary, this hepatic diverticulum forming the intra and extrahepatic ductal system. So the anomalies associated with the development, if there is any arrest during the development, it results in either agenesis of liver or variation in the lobulation of the liver, and the arrest in the development of the biliary system results in agenesis of gallbladder, atresia, bifid, double or intrahepatic gallbladders. Pancreas develops from two parts, the proximal part from ventral pancreas and the dorsal pancreatic buds. From the proximal part of the liver bud, ventral pancreatic bud arises. It rotates to the right side of the duodenal loop to fuse with the dorsal pancreas within the mesoduodenum, and it gives most of the head and uncinate process of the pancreas. And the dorsal pancreatic bud arises from the concavity of duodenal loop cranial to the level of liver bud, and it gives part of the head, rest of the pancreas including neck, body and tail. The ductal system early during the development, it is drained by two different ducts, the dorsal duct and the ventral duct, and later the dorsal part of the dorsal duct combines with the ventral part of the proximal part of the ventral duct to form the main duct of pancreas, the duct of Wirsung, and the residual part of the dorsal duct remains as accessory duct of Santorini. The biliary tract collects, stores, concentrates and delivers the bile secreted by the liver to the duodenum. Its motility is controlled by neurohormonal mechanism. It is divided into intra and extrahepatic bile ducts, and there are significant variations in the biliary tree with the classical pattern present only in 60% of the cases. Bile canaliculi from various segments of the liver unites to form segmental bile ducts. The segmental bile ducts from the posterior segments 6 and 7 unites to form the posterior sectoral duct, and from anterior segments they unite to form the anterior sectoral duct. Segmental bile ducts from the left lobe liver segments unite to form the left hepatic duct, and the bile duct from the caudate lobe, the segment 1, drains at the union of these ducts. Then the common hepatic duct formed by a union of the right and left hepatic duct combines with the cystic duct draining the gallbladder to form CBD. The common bile duct travels initially in the free edge of the lesser omentum, then courses posteriorly to the duodenum and pancreas to unite with the main pancreatic duct to form ampulla fata, which drains at the major duodenal papilla. There are various imaging modalities available, including indirect and direct imaging. Indirect imaging includes X-rays, transabdominal ultrasound, endoscopic ultrasound and intraductal ultrasound. CT, MRI, CT cholangiography, MRCP, radionuclide studies, and the direct imaging includes ERCP, intraoperative cholangiography or T2 cholangiography, and percutaneous transhepatic cholangiography. This is the comparison showing the advantages and disadvantages of various imaging techniques according to their portability, safety, operator dependency, the cost, staging in malignancy, and tissue sampling. Only few conditions can be diagnosed on radiograph, including gallstones when they are very dense and sufficiently calcified, emphysematous cholecystitis where we see intraluminal and intramural air within the gallbladder wall and its lumen, and porcelain gallbladder where we see the calcification of the wall of gallbladder, which is seen as a pear-shaped structure in the subhepatic location. Oral cholecystography is a historical examination. It was used to study the gallbladder opacification after oral contrast. It was a gold standard before invention of ultrasound and CT. Transabdominal ultrasound is the initial imaging test of choice for the evaluation of suspected biliary obstruction. It's a non-invasive, inexpensive, and readily available. Ductal dilatation is excellently seen on ultrasound. In cases of biliary obstruction, it is highly accurate for detecting the extrahepatic obstruction. It provides accurate differentiation between the liver parenchymal diseases and extrahepatic obstruction. It is less discriminating with respect to level and cause of obstruction in differentiating malignant from the benign causes and in diagnosis of CVD stones and small masses at the ampulla of Peter. Major limitations include poor sensitivity and specificity in retroperitoneal organs, operator dependency, and suboptimal imaging for retroperitoneal structures in cases of obese and increased bowel gases. The bile ducts are seen as lucent tubular structures, anechoic tubular structures with echogenic wall, and the gallbladder is seen as a sac-like anechoic structure with the echogenic wall. Wall thickness should not measure more than 3 mm and always measure the thickness along the anterior wall of gallbladder. The size of gallbladder should not exceed more than 10 cm in length and more than 4 cm in width. If it is more, it is called as hytropic gallbladder. Various pathologies that can be seen on ultrasound includes GB calculi, polyps, cholesterosis, CBD calculi, dilatation of intrahepatic biliary radicals. CT cholangiography is also a historical technique. Instead of using oral, here we use IV contrast, especially the sodium iotroxate, and the adequate contrast excretion relies upon the normal liver function. So the technique usually fails if the bilirubin level is very high, if it is more than 2 to 3 times of the normal. CT is not used for direct imaging of biliary. It is useful in diagnosis of liver, gallbladder, and pancreatic diseases. It can identify the pathological dilatation of intra and extrahepatic bile ducts. Also helps in identification of cause of obstruction and the level of the obstruction. Sensitivity for identification of bile duct stone is low unless the stones are very calcified and high in density. It can identify gallstone, cholecystitis, and pancreatic malignancies very well. Various CT images showing the dilatation of intrahepatic bile ducts with cause of obstruction at the region of pancreatic head. We can see here the hyperdense calculus in the distal CBD and hyperdense calculus within the gallbladder lumen. It is commonly employed modality in patients with abdominal pain. It is used to evaluate biliary-related infection and obstruction. CT is not very accurate in detecting the gallstone. However, its sensitivity can be increased by increasing the KVP to 140. It is very accurate in diagnosis of acute cholecystitis and emphysematous cholecystitis, especially in patients of diabetes. MRCP is a non-invasive technique for delineation of the pancreaticobiliary ductal system. It provides cross-sectional and projectional images of the ducts. It does not require any administration of IV contrast. It is based on heavily titulated images which delineates the static fluid including biliary and the pancreatic secretions, and is usually supplemented by fat-saturated T1 and T2 weighted images with steady-state gradient acquisition. It is less susceptible. These sequences are very less susceptible to flow artifacts. It avoids invasive complications of ERCP and it supersedes ERCP for many of its diagnostic indications. It is inferior to ERCP in terms of spatial resolution and in cases of ascites and fluid collection in upper abdomen. Images are usually taken in axial, coronal, 2D and 3D formats and provides accurate imaging of the entire liver, biliary tree, gallbladder, and the pancreatic ducts. Two techniques are usually combined: multi-section thin slice and single slice thick slab MRCP images. It is useful in patients with complete biliary obstruction after biliary enteric anastomosis, in patients in whom ERCP or percutaneous intervention procedures are not feasible, also in patients with significant symptoms, or in patients with complicated biliary diseases. MRCP and MRI is often indicated when CT and ultrasound findings are inconclusive. However, the potential limitation is the pneumobilia. This is the classical pattern of intrahepatic and extrahepatic biliary ductal system and the pancreatic duct, which is normally seen in 60% of patients. Various variants in the intrahepatic ductal system includes right posterior sectoral duct. This is the classical pattern seen in 60%. Second most common pattern is the right posterior sectoral duct draining into the left hepatic duct, seen approximately in 15 to 16% of cases. Trifurcation anomaly is usually seen in 14 to 15% of cases. Right hepatic duct draining into left hepatic duct, and aberrant right and left hepatic duct draining into common hepatic ducts, seen in 2 to 5% of cases. This is the most common variant, right posterior sectoral duct draining into left hepatic duct. Second most common variation, the trifurcation anomaly. Here we can see reversal of the union of right and left posterior right and left sectoral ducts. The right posterior sectoral duct draining onto the inferior aspect of the right anterior sectoral duct. This is the most common variant, right posterior sectoral duct draining into the left hepatic duct. These are the aberrant right posterior sectoral duct draining onto the right side of common hepatic duct. This is another variant, the right posterior sectoral duct draining onto the right side of common hepatic duct. This pattern is seen in 5%, and this pattern is seen in 2% of cases. Here we can see the right posterior sectoral duct draining into the left hepatic duct and accessory right anterior hepatic duct draining into the right posterior sectoral duct. Here we can see the accessory left hepatic duct draining into the right anterior sectoral duct and the right posterior sectoral duct, forming a trifurcation pattern. This is another projected MRCP image. We can see here the right posterior sectoral duct draining onto the inferior aspect of left hepatic duct. Another common anomaly, the right accessory left hepatic duct draining at the right anterior sectoral duct and the right posterior sectoral duct draining into the accessory left hepatic duct. Aberrant bile ducts is the only duct which drains the particular hepatic segment, and the accessory bile ducts is an additional bile duct draining the same area of the liver. Subvesical or subvesicular bile ducts. It is important to know this variant. It accounts for the significant portion of post cholecystectomy bile leaks. Cholecystohepatic duct usually arise from the segment 5 and connects with the gallbladder. They are commonly known as bile ducts of Lashka, first described by Hubert von Lashka. There are 4 different types of subvesical ducts. First is the segmental or sectorial subvesical duct, which is the normal duct which runs close to the gallbladder fossa and drains into the right posterior sectoral duct or common hepatic duct. Second one is the accessory subvesical duct, which is additional duct usually arising from the segment 5 and running within the gallbladder fossa and drains at the common hepatic duct. Cholecystohepatic duct, it connects the gallbladder with the segment 5 sectoral duct. And aberrant subvesical bile ducts, these are mesh-like structures which connects the gallbladder with the segment 5. This is the post cholecystectomy ERCP showing the leak from the subvesical ducts. Normally the gallbladder lies adjacent to the inferior surface of liver within the plane of interlobar fissure. Different positions includes under the left lobe in situs inversus, intrahepatic or subcapsular location along inferior surface of right lobe of liver, transverse or retroperitoneal, which could be congenital required, and agenesis of gallbladder is very rare. Other variations includes Phrygian cap, which is seen as the folding of the gallbladder. Junctional force usually are seen along the posterior wall. Septae results from the extension of spiral wall of Heister, and it results in stasis and stone formation. And when it is multi-septated, it gives a appearance of honeycomb. Other variations include duplication, triplication, bifid gallbladder, and GB diverticulum. Phrygian cap is an ancient greaved cap with its folding at its tip. Here we can see the CT cholecystography and the ultrasound images showing Phrygian cap. Septations, here we can see ultrasound and CT images showing septations within the gallbladder. Cystic duct drains the gallbladder into extrahepatic bile duct system. It joins the common hepatic duct to form the CBD. There are three common variations: the low insertion of cystic duct within distal 1/3 of CBD. Second common variation is the medial insertion of cystic duct, and the third common variation is the parallel course of cystic duct along with the common hepatic duct for running more than 2 cm. This is the low insertion of cystic duct into distal 1/3 of CBD. This is the medial insertion, long course of the cystic duct inserting on the medial aspect of the common hepatic duct, and this is the parallel course of cystic duct running for more than 2 cm along the common hepatic duct. Other variations include high fusion of cystic duct, aberrant fusion of cystic duct with the right or left posterior sectoral duct, and aberrant drainage of the accessory right posterior sectoral duct into the cystic duct. Choledochal cysts can be congenital or developmental. These are thought to result from anomalous pancreaticobiliary junction. They result in fusiform or cystic dilation of the intra or extrahepatic ducts. Female to male ratio is 4:1 and presents with abdominal pain, jaundice, and right upper quadrant mass. They are usually diagnosed during childhood in up to 2 to 38% of cases, and Todani has classified choledochal cyst into 5 different types. Type 1 is the fusiform or saccular dilatation. It is further divided into 3 types: A, B, and C. A is fusiform dilatation, type 1B is saccular dilatation, and type 1C is saccular or fusiform dilatation of suprapancreatic duct. Type 2 is a diverticulum. Type 3 is choledococele, where there is cystic dilation within the lumen of duodenum in the distal part of CBD. Type 4 is multifocal multicystic dilatation of intra and extrahepatic biliary duct. When it involves both the intra and extrahepatic duct, it is type 4A, and when it involves only extrahepatic duct, it is type 4B. And type 5 is multifocal multisegmental cystic dilatation of intrahepatic biliary radicals. Here we can see on projected MRCP image type 1 choledochal cyst with fusiform dilatation. Here we can see saccular dilatation. Here we can see the diverticulum with multiple filling defects within the diverticulum. This is the projected MRCP and ERCP image showing the choledococele, and MRCP and ERCP images showing multifocal multisegmental cystic dilatation of intra and extrahepatic duct, which is the type 4A choledochal cyst. Carlisle's disease, also known as type 5 choledochal cyst, first described by Jacques Carlis, and there are 2 different variants, Carlisle's disease and Carlisle syndrome. When it involves a larger intrahepatic duct, it is called as Carlisle's disease, and when it involves a smaller bile ducts with congenital hepatic fibrosis, this is called as Carlisle's syndrome. Various associations include congenital hepatic fibrosis, medullary sponge kidney, ADPKD, and ARPKD. Here we can see multifocal, multisegmental, intrahepatic cystic lesions communicating with the biliary tree, and here we can see classical central dot sign with the portal radical within the dilated cyst. This is a Carlisle's disease. Type 6 choledochal cyst. It's an isolated cystic dilation of the cystic duct. It was not included in the Todani's classification. Serradell described it first with a case of isolated cystic dilatation of the cystic duct. It is further divided into 2 types. In type 6A, it is dilatation of the CBD and the cystic duct, and in type 6B, there is cystic dilatation of only cystic duct. Differential diagnosis include polycystic liver disease, peribiliary cysts, biliary hematomas, primary sclerosing cholangitis, and recurrent pyogenic cholangitis. Anomalies of the pancreas include congenital variants including annular pancreas or hypoplasia or aplasia of pancreas. Ductal variants include rudimentary duct of Santrini, dominant duct of Santrini, ansa pancreatica, pancreatic divisum, and ectopic pancreas. Annular pancreas incidence is very rare. It is due to incomplete rotation of ventral anal. and it could be extramural or intramural. When it's extramural, the ventral pancreatic duct encircles the duodenum and joins with the MPD, and intramural cases, pancreatic tissue intermingled with the muscle fibers and drains through smaller duct directly into the duodenum. There are two different theories describing the development of annular pancreas, Lekos theory and Baldwin's theory. Here we can see the enhancing pancreatic tissue seen encircling the second part of duodenum, the hypointense pancreatic tissue encircling the duodenal lumen, and the duct of annular pancreas draining into the MPD. Hypoplasia is due to either absence of ventral or dorsal anulge. Hypoplasia in the dorsal component is more common, and it needs to be ruled out through in case with the pancreatic carcinoma when there is upstream dilatation and upstream atrophy and dilation of the ducts. Agenesis, total agenesis is very rare and is incompatible with life, and partial agenesis associated with the other GIT malformation including polysplenia and asplenia. Ductal variants includes bifid configuration with the dominant duct of Wirsung, bifid configuration with dominant duct of Santorini, and the rudimentary or non-draining duct of Santorini, pancreatic divisum where the dorsal duct drains separately at the minor papilla and the ventral duct drains at the major papilla, and ansa pancreatica where the Santorini duct of Santorini forms a sigmoid loop surrounding the duct of Wirsung. This is the pancreatic divisum seen on projected MRCP and CT images. Ansa pancreatica is a rare type of anatomical variation of pancreatic duct. It is a communication with the dorsal duct of Wirsung and the duct of Santorini, and it forms a loop surrounding the duct of Wirsung. This is a case of ansa pancreatica. We can see here the duct of Santorini surrounds the loop, forms a loop surrounding the duct of Wirsung and drains at the minor papilla. Variation in the course includes descending course of pancreatic duct or the vertical course of pancreatic duct, sigmoid course, and the complete loop within the dorsal main pancreatic duct, and anomalous union of pancreatic duct with the bile duct. Here we can see projected MRCP images showing the sigmoid loop, complete loop, duplication of the pancreatic duct in the distal part and in the proximal part. The sphincter of body is formed by three smooth muscle layers, and it surrounds the main pancreatic duct and the CBD. Anomalous junction occurs when there is a fusion of main pancreatic duct and the CBD outside the duodenal wall. It results in formation of long common channel, which is usually more than 15 mm long. It results in reflux, cyst formation, and choledochal webs formation. There are four different types of pancreaticobiliary maljunctions. Type A is a stenotic type, where there is a stenosis in the distal part of CBD. Type B is non-stenotic type. Type C is a dilated channel type, where there is dilatation of the common channel. And type D is a complex type, where there is a complex communication between the pancreatic duct and the distal CBD. Here we can see the anomalous pancreaticobiliary junction with a dilated long channel and associated choledochal cyst type 4A. Incidence of ectopic pancreas is 0.6 to 13%, and usually the ectopic tissue ranges between 0.5 to 2 cm in largest dimension, and it rarely becomes malignant, mostly seen in the submucosal location with the descending order in stomach, duodenum, and jejunum, and lastly in the mucus diverticulum. So to summarize, evaluation of anatomy and the variation is very crucial for evaluation before hepatic surgery, for evaluation before complex interventional BD procedures, especially before percutaneous and endoscopic interventions, and evaluation of suspected biliary tract obstruction, and especially in evaluation before laparoscopic cholecystectomy to avoid any post-cholecystectomy bile leaks. Ultimately, the management of the patient depends upon local expertise, availability, cost, and the multidisciplinary collaboration between radiologists and the surgeons. Thank you so much.
Thank you, sir. Now I'd like to request Dr. Ajay Ware sir to felicitate our speaker, Dr. Sajjad Ali sir.